First of all, I acknowledge all the traditional owners of the lands each of us stand on and pay my respect to their elders, past and present. I'd like to welcome everyone and welcome our guests today. So as we all know, doctors are under more pressure than ever, especially after COVID. So we doctors live unique and very stressful lives, and for too long we have been exposed to that chronic stress, and it seems that COVID has kind of precipitated some further stress to many of us, if not all, in many aspects of life. And we tend, unfortunately, to experience poorer mental health outcomes than the general population. So we'd like to welcome our guests. We've got Prof. Pat McGorry, who's the Director of Orygen Youth Health and the Director at Australians for Mental Health. We'd like to welcome Prof. Brett McDermott, who is the former Beyond Blue Board Director, as well as a Psychiatry Professor at James Cook University. We'd like to welcome Tani Britson, who's the founder of Hand in Hand Peer Support and is also a Psychiatry Registrar at Melbourne Health. We'd also like to welcome Kieran Allen, who's a Senior Psychiatry Registrar at Monash Health and also an Executive at Hand in Hand. Thanks all for joining us. So I think we'll start with Kieran. You've had a few things for us.
Thanks, Nadine. Thank you for everyone who's turned up. It's a really good turnout to see. I think we're at 52 at the moment. And thank you in particular to Tani, who's put a ton of effort into putting this together through what has been some tricky and challenging times. What I want to predominantly talk about is my story and my thoughts about how my professional life has gone as someone who has been working and living in the mental health sphere for some time. So I want to take you back to when I was in medical school. This wasn't the start of my difficulties with mental health, but it sort of was the pinnacle. It was kicked off by some significant bullying that went on from a consultant that I really struggled to interact with, and I'm not sure why, but he seemed to single me out as someone to target, and would find ways to really denigrate and embarrass me on repeated occasions. And this went on for weeks and weeks and weeks. And as a third year medical student, I was quite overwhelmed by what was happening. I really took it on myself and blamed myself for what was happening, and feeling a lot of feelings like I wasn't good enough, like I wasn't doing well enough as a student, despite the fact that the expectations that he had were quite unreasonable. And it was evident even to me then that even the registrars were not meeting the expectations that this person had. So what this led to for me was a period of severe depression, and this stretched on for some months. I had seen my GP and I started on an antidepressant, but that was not sufficient. And despite getting out of that rotation eventually, I continued to slide downhill until eventually I attempted suicide, which was a bizarre experience, to say the least, coming through. Waking up and having thought that everything was going to be over and better, and coming back into the reality that that's not the case was awful. But I dealt with it in a very strange way, I think. 2 days later was back at the hospital. I was back doing my normal thing, trying to study, trying to function as I had been for most of that year. And two important events happened that really shifted the course of how things went for me in terms of my treatment and my well-being. And they were not clinical interventions. They were connections that I'd made with my colleagues, or I should say that my colleagues reached out and made with me. The first was about 2 days after I came back to the hospital. One of the people in my tutorial group was aware that something had happened. There were, physical signs that something had happened, and she commented on it to me, and she told me, "I'm really worried about you." And she gave me the number for VDHP, Victorian Doctors Health Program, and as a result, I got in contact with them and was referred on to a psychiatrist, which improved my treatment, but it didn't fix everything. Things progressed along for another couple of months, still going on quite poorly, to the point where I needed to be hospitalised. At that point, I was suicidal once again, and I was hospitalised in the very hospital that I was studying at, which was a bizarre experience. 2 of my friends, again from the same group, came and visited me on the mental health ward. I didn't know that they were going to do that. I didn't even know that they knew I was there. And I don't know why, but that connection that they made reached out and said to me that they were willing to see me as more than just a colleague, but as someone worthy of respect and of care, and as a whole person who was struggling with something. I was speaking recently about improving the psychological distress that we as doctors experience. And I was approached by someone afterwards this was someone I knew, and they asked me, why? Why do doctors have it harder than anyone else? And I thought it's a good question. Maybe we don't. Maybe we have inherent flaws or inherent ways of being that allow us or don't allow us to address the problems that we're facing. I thought about this and I thought we practice in a profession, as Nadine said, that's unique, where the public perceive us in some way, our patients see us in some way, and the experiences that we have are often quite different. So whilst this gentleman who was speaking to me sees medicine as a rewarding and a well-remunerated career, there's this whole backdrop to it where we live with these tiny cuts that just nip at us every day for different reasons. We're seen as capable, we're seen as heroic at times. That word gets thrown around, particularly was thrown around during COVID. In the lockdowns, we had the frontline heroes, and we're seen as infallible and that we can take on anything. And the reason for that is that our patients often need to see us like that. They're going through very distressing emotions around morbidity and mortality that they may never have confronted before, and they need to look to us as a source of strength. So whilst we might not wear a lab coat anymore, we certainly wear the metaphorical cape and become that superhero from time to time. So this facade is challenged. We're constantly feeling a pressure to do more with less. There's this sense that we have to be the arbiters of who's deserving of care and who is not. And as a psychiatry registrar, that's particularly so. We're doing longer hours, we're confronting the challenges of shift work, and even things that are routine, like the loss of a patient despite our very best efforts, they hit home, and we own them as things that we irrationally should have done better with. So when we think about it, medical training and what we go through from medical school all the way through our training is as much about this process of othering as it is about learning the skills and the art of medicine. We are instilled with this us and them mentality. And one of the first things we learn is how to adopt the not patient role. Think back to medical school. Every time we're learning about an illness or a disease, we start to think, oh, maybe I've got symptoms of that. And we start to, almost become this hypochondriac about these illnesses. But by the time we finish, by the time we graduate, we're immune somehow. We think of ourselves as invincible to, or that we should be invincible to any kind of fallibility. In fact, we crave that image because we think that it's the right thing to do. We think that it's the way to get ahead. We crave the approval of our peers and our supervisors. And we aim to get it through dedication, through self-sacrifice, through staying back, through, going that extra mile. And we attempt to hide the parts of ourselves that don't support that image. What it leads to is that when people start to become distressed, we see them as impaired. We see them as somehow not meeting the professional standards that we're holding ourselves to. Distress is a normal part of the human condition. So why in our profession does it cause so much shame? What we have to deal with when people like myself, as a result, are going through this is this awful balancing of competing identities. So on the one hand, we're trying to be perfect and we're trying to do well. On the other hand, we're trying to live authentically and we're trying to live as complete people. I remember meeting a patient on the ward a couple of years ago who had attempted suicide in a very similar way to what I had done. I found that extraordinarily confronting. And the only way I could deal with that was to shut down and to split those two identities apart so that I didn't have to face the difficulties of what it meant to have that part of myself in my history while I was trying to provide care to this person. Too often, I think, our reaction when people are feeling vulnerable and distressed is that we sideline them. We ostracize them, we see them as requiring individual treatment. We don't look at the systemic issues and the systemic problems that are causing this person to feel distressed. It leads to this conspiracy of silence where we don't ask how people are going. We don't tell if we are, how are you doing? Yeah, good. In fact, I had a supervisor as recently as last year. There's someone I really respect who is a great supervisor otherwise, told me not to share my lived experience with the clinicians that I work with in case they saw me in a poor light. So I've reached the conclusion that we're at this crossroads. We're at this point I would call qualified tolerance of this distress that people experience. We can acknowledge that these stresses face all of us as a collective. We can put on our crazy socks and we can talk about the mental health challenges that people are facing in medicine. We can applaud those even that have sought help and recovered, but we still struggle to tolerate that distress when it's happening. We don't know what to do with it. We let people go off on sick leave for extended periods, but we don't let them take a day off to go and see their psychologist. When was the last time you took a day off to attend an appointment at 2:30 in the afternoon? It just doesn't happen in medicine. And even this is conditional. We expect people to get better. So people who have chronic illnesses or chronic anxiety, recurrent depression, they are still seen as the problem rather than trying to solve the systemic issues behind it. So we can't dig deeper and accept the structural nature of medicine might be to blame. As a profession, we are abrogating our responsibility to EAPs, to work cover, to psychologists, to counsellors, but we're not taking responsibility for caring for one another. So the solution we've got at the moment, it's buying into that false paradigm that we're suffering individually, that our own lack of resilience or our own fragilities are to blame for derailing us. Doctors don't need time out in the early stages of distress. They need support. They need care. And that's most readily available from people closest to them, like those who have reached out to me when I was in a dark place. Now, that's not to say that clinical interventions are not warranted, but they may not be necessary for everyone. And if we're pushing everyone towards that, we're just pathologizing what is a normal part of human life. I'll leave others to talk about peer support in more detail and to talk about hand in hand, but just to point out that hand in hand came about during COVID as a response to that, and to say that we recognise that this is a universal issue in healthcare that is confronting all of us. This disease that we're going to have to fight as a team to protect the community, to protect ourselves, we got together and we banded together around this. But the reality is, this has been happening. The need for peer support, the need to take care of one another has been there for a long time before COVID. I want to leave you with a
Thanks so
question.
much, Kieran.
So this is a quote. Just one second, Nadine, then I'll finish up.
Sorry, there is a bit of a
quote.
lag, that's why.
Yeah,
Keep going.
This is a quote from the Philadelphia Medical and Surgical Reporter. It says, "Our profession is more prone to suicide than any other, as there are special reasons for discontent, which apply with exaggerated force to physicians." So that was published back in 1897. Why are we still having this discussion?
Thanks so much, Kieran. That's really touching. And I can see that there are a few comments and questions in the Q&A and in the chat box. So we'll get to that in the Q&A part of the discussion. I'd like to invite Brett to speak to us a little bit about doctors' wellbeing.
So thanks very much, Nadine. And Nadine, if you can just wave at me, if you could hear me. I get nervous about talking to myself. Good, very good. Kieran, thanks very much. I think in a time when you've got some professors on screen who are in danger of giving you facts and numbers and stuff, it's lovely to hear about lived experience right off the bat. And I think that was very, very moving. So thank you very much for that. Look, just a couple of reflections. I think that I'm looking forward to the Q&A and having more of a conversation. So you won't get a lot of time from me in this little fixed moment. But a couple of reflections. And one is that, you know, every time in someone's career or in their life, you know, an opportunity comes out to call out something. Something that's wrong or something that's really got to be, you know, brought to sort of conscious and public attention. And I think that in the last year, we've been kind of very privileged to see things called out and possibly social media has helped this, but certainly who could not be moved by the Me Too movement and the incredibly brave people who brought that to the public attention. And who could not be moved by Black Lives Matter movement. I think for our profession, not only medicine, but healthcare in general, we are at this juncture, and it's possibly provided by, you know, it's been made more acute because of COVID, but, you know, we have the chance now to call out everything that Kieran talked about, okay? This opportunity won't come up, you know, every year. It won't come up for a while. We have an opportunity now, and that's really to keep the momentum around doctors and healthcare's well-being. And I would really, you know, really entreat people to get on board with this conversation, and, you know, to tell stories about their own mental health, to tell stories about what helped and what didn't help. And you know, for instance, very few people know that I left my first professorship in Western Australia through depression. I was actually severely depressed. And I remember my friend, a paediatrician, tells a funny story about coming in, well, it's not that funny really, coming into my office and I'm standing there kind of in tears, and he kind of came up and hugged me. And I thought this was very strange behaviour. What was this all about? You know, and he said, you know, you're depressed. And of course I was the young professor of psychiatry, and I had, you know, I thought this was a revelation. I was depressed. And then of course he said, I'm taking you to your GP. And he looked at me and he said, you don't have a GP. And of course I didn't have a GP. So luckily we went to his GP, who asked, you know, a series of very standard questions about depression, which I answered yes to every one of them. So, you know, I think that the more we tell those kind of stories, and since then, you know, I've obviously did well from a combination of antidepressants, and they drag someone out of retirement to do therapy with me because no one else would see me. But I wouldn't suggest that, I've had a diminished career since then. I think I've been more insightful about mental health since then. Look, I want to say a few things about, what we know about doctors' mental health. And of course, before COVID, not only the Beyond Blue study, but from around the world, there's been a series of, large N, epidemiologically sound, good measurement, psychometrically sound studies that have showed that doctors are as prone, or as Nadine said, more prone to these things than a lot of other people. And if you got a young person and said, this is the profession I want you to join, that, by the way, in the last year, 55% of the members of this profession will be feeling exhausted, that 10 to 20%, by the way, at any one time have psychological distress, that what compassion you had is in danger of you having compassion fatigue. And by the way, 25% of the profession in the last 12 months feel suicidal. I reckon there'd be some suggestion that you might have, be able to do something better with your life, or at least less stressful. I was interested to see a study out of the, it was reported by the Royal College of Psychiatrists, but it was about doctors in the NHS that only came out last week. And it said that of the doctors surveyed last week, 21% were thinking of leaving the NHS for a non-medical career. Okay, so it's 1 in 5 thinking of actually leaving the career. A quarter were thinking of taking a career break, and 31% were thinking of early retirement. Now, one assumes a lot of those numbers were the same person, or else there'd be no one left to treat our English, cousins. But again, not something you'd rush to join a career which had those kind of numbers. So I think that it's just this time to call out the problem. It's a time to, it's a time to actually acknowledge it and do something about it. In the discussion later, I'm sure we're going to talk about what you can do. So I don't want to, preempt much of that. But some of it's not just the usual things that everyone should do to look after their mental health. Some of it's about what the profession needs to do to change. One of a registrar I talked today, who's a very good registrar and didn't train, in fact, all registrars I deal with are very good, didn't train in JC or another system. I said, in a couple of words, define your experience of a medical student. And this person said, oh, that's easy, fear-based learning. And I thought, oh my God, fear-based learning. Is that the kind of profession that we kind of aspire to? Is that the kind of word association you want to put upon 5 or 6 years of your life? And I think we've all experienced that kind of learning. I mean, I remember a senior nurse telling me to watch out for flying instruments in theatre from a very senior medical practitioner. That was fear-based assisting. Okay. These things I think we actually have to face and address. By the way, the Beyond Blue survey did ask people about why they didn't get help. And some of the things I think we really need to address, things like embarrassment. I mean, are we really going to be embarrassed about talking about an illness of which the prevalence is very high and some of us treat every day? A feeling we should rely on ourselves. Well, we don't expect that of our patients. Worried about confidentiality. Something like 50% of the respondents were worried about the confidentiality of the conversation with their doctor. By the way, the respondents were doctors, which is very surprising. And of course, not having enough time to get help. We don't need to talk much about that. So anyway, thank you, Kieran. That was a wonderful start to our evening. I'll leave it there. I just want to end with, this is a conversation that we need to take very seriously and continue. And I look forward to talking in the panel chat further about these issues. Thanks, Nadine.
Thanks very much, Brett. I'm touched by the fear-based learning, which actually describes it very accurately. So we'll talk about that further, and I can see that the questions are building up in the Q&A section, but we will get to that in the panel discussion. I'd like to ask Tani to talk to us a little bit about hand in hand.
Thanks, Nadine. I think I'm the odd one out because I am the person who's actually made a PowerPoint. But I just thought it would be a good way for us to, or for me to give a bit of an overview of hand in hand in a very quick way. So can everyone see my screen? Perfect. So I just wanted to give a bit of a general overview of hand in hand and also let people know how they could actually come to us and seek support. Basically, in a nutshell, the story of Hand in Hand, which stands for Helping Australian and New Zealand Nurses and Doctors. As you heard, it came about before COVID actually came to Australia. And most of the people in this room were involved in the initial discussions, where we sort of said we needed something that would support our colleagues if we were hit as badly as overseas. And the idea that we came up with was this peer-to-peer support, being that colleagues support colleagues. And it's based on the fact that people who are also in the same position as you or the same role as you, they have an understanding, and you have this mutual understanding of the stresses and the things that you face, and that actually helps you to work through those things. So in terms of hand in hand, the way we work hand in hand is it's actually a preclinical service. So we don't provide clinical level care. It's based purely on peer-to-peer support. So there's no Medicare items, there's no record keeping. People can come to us in an anonymous fashion to begin with. And we're an entirely volunteer-based organisation. So I think most of the people on this screen that you see are all part of Hand in Hand, and we all volunteer our time because we believe in the value of peer support in the medical profession. And I just wanted to give a bit of an idea of how it happens. So people sign up to us, and we'll make sure that we get Daniel to put the link in the chat box so that everyone can see it and have a look at our website as well as some of our resources. But we take people through a process whereby they're triaged, and they're then put into groups depending on their profession or their background or their level of career. And the other thing we do obviously is provide some training and some education around peer support. And I'm very happy to answer questions about this in the panel later, because I think peer support has been needed for a very long time, but for a lot of people it is a very new concept, but we feel it's a really important thing to continue in the medical profession. But I just wanted to highlight that again, the service that we provide at Hand in Hand is completely free, and it's different than treatment. So we're not providing therapy or clinical treatment. It's not supervision, it's not mentorship, and it's not advocacy. It's about people in the same career having a space where they can share experiences and talk about these things. And that's just a visual representation of where we kind of sit in the whole scheme of things, just to give people a bit of a visual representation. But the main thing that I actually wanted to share tonight is something that's quite exciting for most of us. And obviously there's been a number of losses in Far North Queensland and a number of suicides in the junior doctor and medical student population. And that's what really sparked us to do this event for Far North Queensland and JCU and the hospitals up there. And one of the things that we're very excited about and that we're working on with the JCU Medical Student Association is rolling out peer support for medical students at James Cook University. So for those of you who are medical students and who haven't heard of this or who haven't seen this, we're in the process of seeking expressions of interest from any medical student from JCU, so from Mackay, Townsville, Cairns, wherever you might be in terms of placements, whether you're in rural, whether you're on a experience somewhere else, you can sign up to us to have peer support with your colleagues at JCU who will undertake our training program. And we're really, really passionate about beginning this program. So it's being run by Brett and a Psychiatry Registrar in Townsville. And please feel free to ask us more questions about this during the Q&A. I think I'm very short and sweet tonight, but again, happy to answer any questions people might have in the Q&A. I'm just very wary of time.
Thank you very much, Dani. I found the slides really helpful because it kind of sticks to the mind. So that's really good. Thank you. I can see that some people are sending questions in the chat box. Can I please, just so that we don't miss any questions, ask that everyone puts their question in the Q&A tab? We will make sure that we don't miss the couple of questions in the chat box, but please remember to put it in the Q&A because we will take it one by one. I'd like to invite Pat to talk to us a little bit about the bigger picture of things.
Yeah, thanks very much, Nadine. And I can't talk about the bigger picture without responding to the smaller picture, because it was very, moving, as you all said, but not just moving, but insightful, incredibly insightful what Kieran and Brett were saying, and just reminded me of my early career too, and I trained back in the late 1970s. I was a junior hospital doctor, both in Newcastle and New South Wales, and then in the UK after that. And I mean, the schedule, that what you were expected to do was just, relentless in terms of the hours and the exhaustion. I'll never forget it really. And I did that for about 4 years. But I also had the experience of being bullied. So I was very much relating to what Kieran was saying. And, it was basically by surgeons, not surprisingly, but, they just set out to humiliate basically. And it was almost like a test. And so luckily I did have good support, and I sort of, I don't know, I wasn't planning to stick around in that hospital anyway, so I probably had a bit of an escape route, which maybe Kieran may not have had at that point. And he was a student, by the way, not an intern. I was an intern at the time, so I can definitely relate to what Brett and Kieran are saying, and without support, you just wouldn't get through it. But I think in terms of the bigger picture, what it sort of says is it's the culture. Kieran was talking about this. There's something wrong with the culture that operates like that. And Brett's done the studies with Beyond Blue, but there's also studies done in the legal profession in Sydney that showed the same type of stuff actually. So I don't think we're unique actually. So the bigger picture is, what's the broader canvas here? I think every person that develops mental ill health is coming out of a context, and a set of, we've all got vulnerabilities. I mean, like Kieran was saying, we've all got different sort of risk factors within ourselves and also within our environment. And one of the environments that we're talking about here is the culture of your, vocational pathway. And it's supposed to be scaffolding around you that helps you sort of, develop and mature and become, stronger and more sort of, what's the word, more competent and more skilled. But a culture like this sort of undermines a lot of that, doesn't it? Especially the sense of self-efficacy and confidence and identity. It's supposed to be a vocation, medicine and healthcare, and yet a lot of the forces are sort of trying to undermine that. So the culture could be improved, couldn't it? I mean, and there are obviously great cultures in medicine too. There are places that are very different from that. Our mental health culture, mental health system culture has been degraded in recent years. That's why we've had a Royal Commission here in Victoria, because all of the mental health professionals have not been supported properly to do their job, and the patients then suffer as well, of course. So it's like culture is incredibly important, and so this is the beauty of what you've been focusing on with Hand in Hand, and I was very excited to sort of talk with Brett and Tani and others about getting, when that was sort of forming, and so much needed, and the power of peer support. So that's another big picture thing, and peer support is obviously becoming a big thing in mental health, because it's a very important ingredient in sort of protecting people. It doesn't mean it prevents mental illness. I was thinking about what Kieran said about the boundary between what sort of help you need. It's like a false dichotomy, isn't it? You need that peer support even if you are needing professional help as well. So it's in both sort of areas, I suppose. But if the culture was more healthy and more what's the word, healing or positive, or like a nurturing culture and developing an improvement culture, then that would remove a major risk factor from what we're actually dealing with. And I don't know if it's better or not. It's sort of shocking for me to hear those stories in this day and age, to be honest, after, I think it's over 40 years ago when I was in that situation. And it's kind of shocking that people like Kieran can have those experiences these days. I mean, it really is. And so, like Brett said, it's a call to action. It's time to not just call it out, but fix it. And I think that the leadership that you see from the young doctors and the medical students these days is fantastic. Like the last few presidents of AMSA, for example, have all put mental health right at the top of the agenda. And I think there's great leadership coming from young people. And Tani is obviously one of those people, and the other people on the call are too. So people like Brett and I, hopefully we can just give you support and, absolute solidarity in what you're doing. And so just broadening it out of the big picture a little bit more, we want to get a fair deal for mental health within the health system. And that's why Australians for Mental Health is very much supporting what's happening here tonight in the Kooyong group, and they can see some value. We want to recruit and engage, young doctors and health professionals generally as part of this almost social movement to kind of extract a fair deal from the health system and from government in relation to mental health care more generally. Because, we've had this mainstreaming thing for the last, 25 years, but it's kind of failed. We still have not got equity within the health system. In fact, it's probably deteriorated a fair bit because it was just dumped into the health system without much proper design or thought, and certainly without recognizing the scale which Brett alluded to of mental ill health. I mean, epidemiological studies that Brett sort of mentioned, that the most important one is probably from New Zealand, which there's that Dunedin study, which followed children in late primary school, I think it was, and that's where they were first recruited, and they've followed through now to age 45. And a paper last year showed that 84% of those children, unselected, just normal population sample, 84% reached the threshold for a diagnosable period of mental ill health at some point during that period. So by the time they all die, you'd have to imagine it would be getting close to 100%. So mental ill health is part of what everyone can expect in their lives, We all expect physical ill health, don't we? We all expect to get the flu. We always expect to maybe have a fracture or two, or, develop some kind of medical illness. Most people go to the doctor, the GP, every year for something or other. So, but we're expected, like Kieran was alluding to, almost being like immune to developing mental ill health. But that's not going to be the case. Almost everyone is going to need some kind of mental health care. It doesn't always have to be heavy professional sort of care, like in lots of psychotherapy or medication, but mental ill health is going to happen to you, in the lifespan. So why is mental illness and mental ill health shortchanged so much? It's just a disgrace, that 2 out of 3 people with mental illness are turned away, and the quality of care available to the third one is well below what could be achieved if it was properly funded and supported, including the workers and the professionals. So that's what Australians for Mental Health is about, trying to mobilise hundreds of thousands of Australians at least in support of a fair deal. And so the politicians who many of whom are sympathetic to what we're trying to do, will actually have the wind beneath their wings. They won't be able to sort of, I mean, they can't really pluck billions of dollars or tens of billions of dollars out of budgets unless the public are really demanding it or supporting it. And the public are not doing that yet. We've been bought off with awareness and, you know, and sort of, you know, are you okay and all that kind of stuff, which is all important, but we've been short. That's been a substitute for actually equity and equality. And that's what we have to change now. The awareness can help us, you know, because now we can turn it into action and a political campaign. That's what we need. And that's what this is in some ways too. Like, we want to change the culture of medicine. It's got to be a political approach as well as a sort of a discussion and supportive approach. So we've got to change hearts and minds. And that's why this is so great, hand in hand. And, you know, it's great to be able to be with you all tonight and share our experiences, and also, you know, turn that sort of frustration and I don't know, that lived experience into action and progress. So thanks for listening, and look forward to the Q&A as well.
Thanks very much, Pat. That's really great to hear. We will start with the questions, but I think the first question would be for Pat, because one of the questions we had in the Q&A tab was, what is mental health? And I acknowledge that we are a bit like a fish in the boiling water, and sometimes it gets blurry as to what actually being well is. And sometimes it takes us so long to actually realize that we are unwell in the first place. So what is mental health, Pat?
So I'm giving all the easy questions to me, are you? So I wrote a piece in the Griffith Review, which just came out today, actually. It was a Queensland publication, and it's a 5,000-word essay in which, you know, that's a big part of it. And so I have thought a fair bit about it lately, and I don't know if the answer is the right answer, but if you just think about what happened with COVID, most people suffered a significant loss of well-being, if you can put it that way. So in terms of their mental health, it deteriorated. But not all of those people developed, you know, mental ill health, did they? So, and they didn't necessarily have a need for care, all of those people. But probably about 20 or 30% of new people or new episodes were produced as a result of COVID. And obviously then swamped, you know, the already overwhelmed system. So the distinction between losing mental health, I think, and we talk about soft border between mental health and mental ill health. If you try to tighten it up too much and operationalize it too much, which everyone wants to do with rating scales and triages and all that kind of stuff, then you're not allowing personal choice or individual, you know, help seeking to be a factor. Like, no one says to a patient with physical symptoms, well, I'm really sorry, but your stomach ache or your chest pain is not really at the threshold on our rating scale that allows you to go and talk to the doctor or to seek help. No one says that. The patient decides. And then you know, there's an interaction with health professionals and doctors about that. But in mental health, we're desperate to sort of work out where the boundary is, you know, and the reason is because they want to use that to restrict access to care, and they use other furphies like labeling and stigma, you know, to discourage people from that. So it's a very complex issue. It's quite contentious. You know, you've got people. We suffered from this when we were developing Headspace, that, you know, Alan Francis, you know, came out because he was campaigning against DSM-5 and tried to argue that somehow we were medicalizing, you know, the problems of young people and turning teenage angst into illness. Well, actually, it was the reverse. You know, the vast majority of young people weren't getting any help at all. So I mean, but it is contentious. You'll have people arguing about this issue and trying to, and there's a lot of confusion. And with the university framework that we developed recently, you know, universities are very happy to run well-being programs across universities, but much more reluctant to provide services to help students who are really struggling and need professional help. So it's a kind of a very important issue to keep talking about and express different opinions about.
Great. Thanks, Pat. That's really useful to hear. I guess I'm grabbing a question from one of the questions that got posted on the chat box, and that was directed to you, Kieran. So the question was, while we are waiting for culture and policy changes, so I think that the initial talk was about unacceptable behaviours and bullying at work, and that may result in mental illness or distress. And while we're waiting for culture and policy changes to remove those perpetrators or the people that participate in this bullying or unacceptable behaviour, what can we do in the meantime to survive? And if you found any interpersonal strategies that you would recommend?
I think the first thing I'd say is that I'd reject the idea that we have to wait. We may have to wait for the policies to catch up with what we're expecting to change, but I think all of us have an individual responsibility to be calling out behaviour that we see as unacceptable. And as a trainee, I would call on, in particular, consultants to call that kind of behaviour out in their colleagues, who are the people who have the power in that relationship. As someone who has had, challenging, as I mentioned, challenging dynamics with a consultant during my training, it's very isolating, and it's hard to know how to survive. And evidently at the time, I feel like I didn't have those skills. Looking back now, what would I do differently? I think that the fear that I had was that people who were collateral to that person would be automatically on their side. And I found that that's no longer the case. So speaking to supervisors, speaking to other consultants, other registrars, and even, from a medical student point of view, talking to the university, which was something I did at the time, did help to protect from some harm. But it is a difficult thing to feel safe enough to do when you're within that sort of power differential that exists in all the training programs, as well as in medical school. But it is important to try and seek to bring those kind of people on board, because they are the kind of person that can have a word in the ear of the person who is behaving inappropriately, which might pull them back into line.
Thanks, Kieran. And may I ask if you, Brett, have anything to add to that?
Thanks, Nadine. Look, I think because it's such a complex issue, I think there's interventions at every level up and down the chain, really. I think, for instance, I've now had a reasonably long career. I think it's over 30 years, and I've seen some senior hospital managers who, in the name of reform, have just engaged in terribly bad behaviour. I actually saw one hospital CEO that, purposely didn't have an office and would meet in a park bench across the road at their discretion, just as a way, I think, of stopping people ever meet them. I've seen senior hospital managers who are very interested in the finances, but not interested in the wellness of their folks. And I think that, I think we should be, as a group, telling hospital managers that particular consultant should not have junior doctors, or junior nurses, by the way, until they improve their behaviour or go somewhere else, hopefully not to inflict it on someone else. I think in universities, we should be collectively saying that particular person's teaching style is not counter to actually learning, because you're so busy being scared and hypervigilant, you don't actually learn anything. So right at the top of the chain, I think we should be doing things. And all the way through, I think, medicine should be preparing people for a life in health. And preparing you for a life in health, by the way, is not about learning facts. It is a learning about how to be up to date with facts and how to check facts and all that sort of stuff. But it's also learning things like not having your sense of self a unitary expression of being a doctor. Okay, people that know me know that after 5, a bit later tonight, I'm not particularly a doctor. I'm one of many things, not a bad artist, a very bad guitarist, a very, a whole bunch of other things. But I don't have this unitary expression of me that's a doctor. And I think that's highly protective, I think people can to do things. They can, emphasize that their non-work time, is you know, is likely to nurture and sustain. They can do all the things we tell our patients all the time. They can look at diet, they can look at exercise, they can look at social connectedness. Social connectedness is highly protective. They can join hand-in-hand peer support. They can do lots of things, you know. So I think that the answer is complex, because I think there's things that you can do as an individual, there's things you can do as a group, there's things you can do with your kind of immediate work group. But I think there's also things that the very top hospital administrators need to do as well. I finished my diatribe.
Thanks, Brett. So I guess the next question we wanted to talk about is, I would say maybe Kieran could answer a little bit of that, and maybe we can ask if Pat and Brett have anything to add. So someone was saying, many of my friends have voiced concerns about taking time off or going to seek help, and the fact that this may compromise them professionally in terms of career progression. Are their concerns valid? And if there is any reassurance, or if there are concerns actually, what can they do, Kieran?
I think that is a fear that I've seen a lot of people have. I don't know if it's founded in reality, but it is certainly very pervasive. I think in terms of career progression, I've seen people who have tried to avoid taking time off and have ended up getting worse and taken time off, myself included, for that very reason. So I think that you need to consider it from both perspectives, and the perspective that if you're at the point where you're considering that you're unwell enough to be taking time off work, you don't just have that responsibility to yourself at that point. You have it to your patients, you have it to your colleagues, and you need to make that call with support. It's impossible to provide concrete reassurance, because there's always the risk that you will run into a manager or a head of unit or something that is going to make life hard for you as a result. I haven't had that happen, so I can only speak to my own experience, and that has been that I've had a lot of support from my employer, from my head of unit, from my medical workforce, from my college, and from my university when I was there. So I think that from my own personal experience, I can say that I don't think that those concerns are valid, but the concrete answer that someone might be looking for can't be given.
Yeah, that's right, Kieran. And I think the issue is, I'm really glad that you have received support and that everyone around you was kind of supportive and of whatever you needed. But I think reality is that at times we don't get the support, and at times we are actually ostracized as a result. And I wonder if Brett has anything that he would suggest to do in such an instance.
Well, I think someone I know at the moment has a huge kind of workload and after hours. So after I say a few things, Tani, I'm going to invite you to talk about your reality at the moment. But you know, I think that we assume, don't forget, we kind of make these assumptions about other human beings, and if you know, if someone worked with me, and I have a registrar at the moment, if they asked me, they would find an incredibly, I hope, supportive response about, I would rather you take time off and, you know, look well and, you know, recharge your empathy and your compassion and, you know, mirror that to patients and show them hope and optimism, rather than, you know, you look like you do at the moment. I'd much rather you go off and recharge, and I'm quite capable of writing my own notes very much, you know, thank you very much. So, you know, I think that people should reach out. It sounded like Kieran did. possibly later down the track. I'm not sure where in the journey Kieran did, but when he did, it worked, which is fantastic. And I think that, you know, amongst registrars, amongst junior doctors, I think they know who to ask and they know who they can reach out to, and they can get supportive things. It's, you know, it's hard to do, but it can be incredibly rewarding. So I would really encourage people not to assume they're going to get a bad response, but to reach out. And of course, if you do get a response that's not helpful, then my approach is to keep going until I find one that is helpful. So I wouldn't get put off. You know, it is well known amongst cohorts of people who's going to be helpful and who's not. I think reaching out is a wonderful thing. And in my lived experience, you know, I let it go too far to a point where I had no insight. I should have reached out, you know, months before. So I could encourage people to do that. So Tani, I've just dobbed you in.
What did you want me to talk about? I guess one thing I would say though is, you know, we've got some comments there about people feeling like they can't reach out or that sometimes the responses aren't helpful. And like Brett said, it's really important to reach out, but fully acknowledge that sometimes, you know, whether it be a university or whether it be a hospital or an employer, people aren't always helpful, and that can be, you know, really disheartening. But I think, like Brett said, there's always going to be someone there that will support you. I know when I was having a hard time in med school, I reached out to this random psychiatry professor and, you know, here I am. So there's always somebody around the corner that will be helpful. So I think that's important. And in terms of workload and balancing life and work, I think that's always a difficult issue, and it's not something I'm great at managing all the time. But it's just something we have to keep working on and try and fit in time for self-care and to have a life outside of medicine.
Great. Thank you so much, Tani. While I've got you, I've got another question for you. And I think that's because you must get that question a lot through people inquiring about hand in hand. So someone was asking, how will a GP help me with my mental health problem?
Good question. First of all, I think, like Brett said before, we should all have our own GP. It's really, really important that even though we're doctors or medical students and we tend to think that we can look after ourselves because we have all this knowledge or this theoretical knowledge, we all really need somebody who's there completely focused and caring for us. And so in terms of a GP, they're really important because they're your sort of first port of call if anything's wrong. GPs, you know, they can do basic psychological assessments. They can pick up if somebody's depressed or if they're anxious or if there's other things going on. And they're really the gateway into seeking help and seeking care. So, you know, they can refer you to a psychologist. They can refer you to, they might say that peer support would be helpful. So they could suggest coming to us. They might need to refer you to a psychiatrist, but they're really that gateway into seeking clinical or even pre-clinical care. So it is really, really important everyone have a GP.
That's really good, Tani.
I'm sure others have things to add, but that's my 2 cents.
Thanks, Tani. Is there anything that any of the panelists would like to add?
Yeah, I'd just like to add that the GPs need backup. I mean, this is the missing middle point. I mean, GPs are constantly frustrated that they cannot get the support that they need to look after anything more than something very simple, you know. And there's the same with the better access model. That might be okay for a certain percentage of people, but there's a whole over 1 million, according to the Productivity Commission, maybe 2 million in my calculations of people who need more team-based sort of disciplinary sort of help and support, and they just can't get it. The GP, I remember talking to Tony Bartoni when he was president of the AMA. He is my local GP, believe it or not, but they just can't get access or support. So that means that they are I suppose, really stressed and worried, and can't do what they play their role properly, and patients suffer. So I think that's a big problem, the way it's configured. And could I just mention, I forgot to mention before, that the Kuyong group are supporting us, hand in hand, and Australians for Mental Health, in making this possible today. I forgot to acknowledge them before, but their generosity is really important, and we need fuel in the tank. Tani and Brett have done this on the smell of an oily rag, really, from day one. I don't know how they've actually managed to do it at all, but there's an amazing effort. But we need to put some funds into this and to support this whole initiative too. So the Kuyong group, thank you.
Thanks, Pat.
Nadine, can I just say something as well? I mean, the GP dilemma, and by the way, I completely agree with Pat, and I thought the missing middle is an incredibly helpful comment. I think some people are very fortunate their GP has a really strong interest in mental health, and I saw a GP recently, and the GP didn't kind of realise that I was fatigued because I'd been working too much in my garden, and actually did a mental health check. This was fascinating for someone who's a professor of psychiatry. They did it empathically. They asked me these beautiful questions, and finally we got to the point that I kind of wasn't depressed. I was just incredibly haggard and fatigued, and I needed to remember my age next time I go into the garden. But some GPs, are just magnificent, and they do really well with mental health. But I agree completely that, for instance, in child and youth mental health, GPs have very, very little places to go at all. I mean, their attempts to help young people, it's scandalous how little resources they have. And of course, it's patchy. Outside of high SES suburbs, it's very hard for GPs to get good specialist help, and that's something we seriously need to address as a profession and as a workforce.
That's right, Brett. I agree. But the next question is a bit of a challenge. So I was going to ask, and maybe Brett should be best to answer that, but then we can have contribution from other panelists. When APRA is not very sympathetic to the doctor who experiences mental illness, how can we change or approach that?
Yeah, it's am I unmuted yet? It's look, it's a really big dilemma, isn't it? And I know very competent colleagues who have, there's been an APRA event and, a complaint. And so that's not quite what you're talking about, but they found it a very difficult process to go through. And of course, both were completely exonerated, but after 2 years of stress and worry. And, I hope that, I hope two things. I hope firstly, we can be, better patients as doctors. So now I go into, a doctor's consultation and say, whatever you've read about my profession, can you assume that I actually know nothing about anything? And, recently a skin specialist assumed I knew something about skin. I'm completely unqualified, completely unqualified. And I needed to point this out to them. So I think we need to be good patients and say, please, please, please treat me as I really, don't know anything about my heck. So I think we need to be better patients, but also as doctors, I think we need to look our medical colleagues in the eye and say, there's two things you need to remember. I'm not going to treat you as a doctor. I'm going to treat you as someone who might have an important diagnosis that I need to make. And I want to remind you that this is incredibly confidential, because all my sessions all my patients I treat with high confidentiality. And that's my starting position. So, I think that as a profession, we have things to learn about being patients and being doctors.
That's right. Thank you so much, Brett. Is there anyone that you would like to add something on this topic? APRA response to mental health.
I was just going to say, like, the other thing to remember, I know we all get really like stressed about APRA, and it's kind of this overarching body that worries us about seeking help. But, you know, realistically, there's been a lot of work from people to reduce the mandatory reporting and to make sure that people are only being reported if they're at serious risk of harm to themselves or others. So as long as you're seeking treatment and, you know, you're not putting yourself or others at risk, that's actually more important than worrying about APRA, because chances are, if you've got a good GP that you trust and a good team on board, they're not going to report you to APRA if you're doing the right thing and seeking help. So I think that's something that we all need to remind ourselves of a lot, and also need to educate our colleagues on too, so that people aren't, you know, wrongfully sort of referred to APRA when they don't need to be.
Thanks, Dani. Anything else to be added?
Well, just to support that point, what I said before about the inevitability of people having mental health problems. I mean, it's going to happen. So most likely. So therefore, you preparing for it and working out what does happen in that circumstance, and maybe, I don't know what sort of process should be put in place to look at how APRA should be involved, you know, in what ways it should be involved. Maybe that's already happening, I don't know.
Yeah, thanks, Pat. All right, well, the next question, I would say for Kieran, and I think there are two questions that I'm going to combine them into one, Kieran, just because we're having more and more questions coming in. So the first one is, have you seen any change in the attitudes of people who listen to your story and to the overall, to mental illness in general? And the second part of the question is, how do you address the feeling of that uncomfortable feeling about talking about your own mental health, or mental illness, or your own distress?
Funnily enough, I don't know if this is a good thing or a bad thing, but the reaction hasn't changed much in the time that I have been talking about things. And you know, the response I often get is, thank you for talking about your story. Have people come up to you and tell you that they've had similar experiences, but that's been going on for years, and the reaction hasn't changed. I still receive the same cautions of not telling my story to the wrong people, of being careful when I'm telling my story, in what circumstances. And there's still a perception that I, as a professional, am one thing, and then I have this other part to me that doesn't contribute to my professional responsibilities, or doesn't shape how I practice as a psychiatric trainee. So I suppose I'm sad that it hasn't improved in that sense. But I think that the fact that people are still feeling able to come and say that they're appreciative of hearing this kind of thing is good. I wrote a piece that was published yesterday in the College of Psychiatrists training newsletter. And a colleague sent me a photo of it, thinking it was written by someone else, and then wrote, "Oh, it's written by you." And I had this feeling of beating a very lonely drum sometimes. That you know, we're going around in circles a little bit, and it's going to take until people start to feel confident sharing those stories that it will actually affect real change. And what I mean by that is, what I was alluding to before. The College of Psychiatrists, for example, acknowledged that there is a value in having people with lived experience as psychiatrists, but that's only really been in the last few years that that's been acknowledged. And how that is valued is not really known, other than to say, yes, they're probably a good idea. But until people start to recognise that any experiences that we're bringing from our personal lives, from our personal experiences as doctors that are shaping the way we practice positively, could be valuable and shouldn't be just squashed down into that corner, I don't think we're going to be able to feel that those reactions aren't going to change, and that we're not going to feel that temptation to tell people to keep things quiet or keep them to themselves. I'm not sure if that answered the second part of your question, but
it does. It certainly does. Kieran, there is a bit of an echo. Thank you so much. It does answer the question. Is there anything else for the panelists to add on this topic? Because it is a significant barrier, I guess, in us seeking help when we need.
So, Kieran, one of the amusing things about the position of acknowledging that lived experience is helpful is that, following on Pat's logic and the epidemiology, 75% of the college members have a lived experience. They're just not owning up to it, And as one gets older, because it's a lifetime cumulative kind of risk, at my age, they've all got lived experience, but they're just not owning up to it. And I think that when we accept it as being a part of the human experience, an unpleasant part and something we should do something about, then, that would be a great day when that actually happened.
Yeah.
Thanks, Brett. So the next question is from Asta. Thanks, Asta, for your question. I will skip the comment because everyone can read it. But the question is probably, Pat, I would pass this question on to you, and maybe the rest of the panelists can add more to it. How do we increase the connectivity at work and bring a cultural change in organizations that we are part of?
That is a great question. I think organizations, we've just gone through this at Orygen. I don't know if you can read it, but it's got the values on this thing. So we went through a process of deciding what the values of the organization actually were. And, I've been a bit cynical about those processes because I've seen, I worked in hospitals where they did all that and you knew that it was fake, they didn't actually translate into the culture. But I must say that I've changed my mind and it does actually mean something that you go through a process like that with all of your colleagues and friends at work and you decide how you're going to behave, and so then it's deviations from that behavior stand out more as well. And certainly if people are struggling, and at Orygen, a lot of people struggle, especially in the last 12 months, with the pressures of COVID, but even before that. And we've had significant numbers of people that have had mental ill health, and I think we've basically, I think we've managed it. I'd love to hear what people think in the organisation, but we've definitely given people as much time as they need and as much support as they need. And some people have actually decided to leave and stop work because they were too seriously ill. Like I'm talking about really serious mental illnesses in some cases as well. But we don't try to hide it, and we don't require people to disclose it. Coming back to what Brett was saying, that would be great in the world if everyone felt comfortable to do that, but not everyone does still. But we try to create an authorizing environment, if I can use that term, or an accepting environment, and that's what we try to do. And so I think the culture, trying to create cultures of safety, you could say, first of all, and also not just safety, but a bit like what Kieran was alluding to, that you can depend on people around you if something goes wrong or if you're struggling this way. That's what organizations should try to do, and maybe these values processes are a way to do it. I know that there's a risk that they can just be tick the box exercises too, so they've got to be genuine, but then So if you've got genuine people in the leadership who've got a vocation, you know, that I think many people tonight have referred to the vocation of medicine and healthcare, and that's something that it's a very, very precious thing, and not all doctors have that actually, you know, but that's what you have to try and create in the environment, and I think, and we're all imperfect. We all just try to move things in that direction. That's what we've got to try and do, I think.
Nadine, if I could just follow that up.
Yes, please.
Like Pat, I was a bit of a values cynic, and then at the Mater in Brisbane, where I was the director for about 15 years, we had the values on the back of our cards, our personal cards, and you know, if someone had done something which was, you know, diminished someone else's, you know, experience, then we could go down an HR route, or I would sit down quietly with them and I'd pull out the card and turn it over. And you could see the look on their face going, oh no, we're going to have a values conversation. I'm going, let's talk about the values of our organisation and how that went. And it was just the most wonderful thing, because we could have this conversation about, and not HR, not about policies and procedures, not about, you know, about, you know, what it was to be a member of this organisation. So again, like Pat, I discovered the power of living the values in an organisational culture, and I think that's incredibly powerful. And again, a bit like Pat, I was the boss and responsible for the tone of the joint, you know, and I think there should be much more, you know. And I wasn't, you know, I learnt this by lucky happenstance. It wasn't something I thought much about. But as a management, you know, culture cannot be underrated in organisations. It's incredibly powerful.
Thank you very much, Brett. There is a question for you, Tani, and it's, how can we help junior doctors find and access a new GP, especially if we're looking for a GP who's more aware of mental health issues? And the question in particular talks about small communities or rural settings when telehealth might not be available. And I know you have your rural experience in addition to your experience with Hand in Hand, so you'll have more to say about that.
Yes, definitely something I've probably also experienced as well, coming from a small town. And I've definitely had colleagues in the past say to me that, you know, we know that we have to have a GP, but who do we know who we can trust and who do we go to? And we're, you know, really worried that they might not understand if we do this and they might report us, etc., etc. So there is a lot of fear and anxiety, but one of the things that can be helpful is, I know there are some doctors' health organisations or groups, like various states, that have lists of GPs who, you know, have been recommended by doctors, or, you know, who have said that they are happy to treat doctors. And also, I think just like actually using your peer-to-peer colleagues and connection to actually ask if anyone has a GP that they would recommend, or sometimes senior colleagues are also really helpful. I think, yeah, the main thing is actually just asking people. And if you don't have anyone you can ask, you can reach out to things like Victorian Doctors Health Program or Queensland Doctors Health Program. Sometimes they do have a master list. It's also something I think we're trying to work on with the AMA Committee of Doctors in Training, is to put together sort of a master list of GPs and psychologists for doctors. So that's a work in progress, but hopefully we can have that as well. Yeah, but I fully acknowledge it is really, really difficult. And I just encourage you to, especially in those small towns, reach out to the colleagues that are from there or who have been there for a really long time, and the seniors, and they're generally able to give you a helping hand. And if anyone's in Cairns or Townsville and is watching this and doesn't know where they should go to get a GP, or would like some advice or, you know, some help, then I think there's a few of us who would be happy to help with this. So.
Thank you very much, Tani. And I think a theme that keeps coming up, and so that's why I'm going to bring it up again, even though we've discussed it, mandatory reporting by APRA. So someone has asked, the mandatory reporting is a huge barrier, and that some people have suffered very negative consequences due to having been reported to APRA without meeting the criteria. So what I was thinking about what you were saying, Tanya, and that actually made sense. If we start seeing a doctor, a GP who's interested in mental health for doctors, he would be probably less likely to report when not necessary. Would you agree?
Is this for me?
Yeah, sorry.
That's all right. I was like, oh,
I felt it was related to what you were saying.
I read that question as well, and I have heard this, and I've unfortunately probably seen senior colleagues try to report people when there may not have been an actual indication. And so it is something that I feel quite passionately about, that I think people really need to be made aware of what is reportable and what isn't reportable. I think there needs to be a lot more education around this, because I guess as doctors and other health professionals, we do get quite nervous ourselves that we might be making an error, or, you know, we might get in trouble if we don't report this. So again, that's sort of like where reaching out to your colleagues and actually discussing this, whether it be peer review if you're a psychiatrist, or whether it be just actual sort of supervision or discussion with colleagues saying, this is the case I have, what do you think? Or talking to people who, you know, even just if you're really, really worried, you can always do a sort of anonymous call to APRA, I guess, as well, and chat with them. But I think reaching out to your colleagues as the first port of call, and making sure that we're all sort of really aware of the rules around mandatory reporting, because they have changed quite a lot recently, to allow people to actually seek help and not be reported unless there is a dire need. I know it's still really scary and it doesn't help, and you still have all these fears, but you know, we as a profession need to work towards actually making a space where we can seek help, and also where our colleagues are aware of when and where and what they need to report and when they don't need to.
I think it's really helpful to put it into context too. So Kim Jenkins, who works with us with Hand in Hand, was and is again the clinical director at VDHP. She told me once that she'd seen over 1,000 doctors, many of whom were referred for, you know, things like substance use, lots of different issues that could warrant potentially APRA involvement. But because they were seeking treatment and they were getting help, they didn't require a mandatory notification. Out of all of those more than 1,000 people, she made 3 mandatory reports. So it was very, very, very rare that it had to happen. Okay, so I think that gave me confidence that it's not a common occurrence and doesn't need to be either, and shouldn't be a reason not to seek help.
That's great data. That's fantastic data, Kieran, to know that.
Thanks, Kieran. Did you have anything to say, Brett?
Yeah, look, I think this is a really interesting part of the discussion. And I had an evening private practice for many years and saw lots of doctors, and I was always impressed by, you know, the willingness of people to come along and get help, and that very act always just incredibly encouraged me that this was going to go in a good direction. And I, probably over 10 years of that, never ever reported anybody. Now, that doesn't mean that, you know, if someone didn't come in with command hallucinations of doing X, Y, and Z, I wouldn't. But the fact is that it's an incredibly rare thing. The other thing, I think, and Kieran mentioned this, I mean, there are, you know, Doctors for Doctors organisations, and they would never not take the phone call to discuss a case. Just like, you know, consultants take the phone call to discuss cases. And I would really encourage people, and if you want to do that anonymously, and don't mention the patient's name, but you know, this is part of our responsibility to our craft group, that you could always ring someone and discuss it. I would probably even, you know, at my level of seniority, I wouldn't mandatorily report anybody unless I got on the phone and had a chat to a few people. I think I think people should be reassured that that is no reason. Of course, and if you put off getting help by those kind of concerns, you'll only be in a worse way when you finally go and get help. I mean, there's the reality of mental health. So go and get help, folks. Go and get help.
Thanks, Brett. I guess there is a question that was repeated again. So there is a common theme here. I think this question could be answered by anyone in the panel. So I'm open to anyone who will put their hand up. So the question is about, is it all right to share your personal experience with mental illness with your patients? Or is this a boundary violation or crossing? And would that impact your relationship with the patient or the trust that they have towards you? Or will it maybe build rapport and help?
That is a very good question. Can I jump in? And it's an incredibly good question. I think we're in a changing landscape in mental health. I mean, if we're talking about peer work as being part of the furniture in mental health care, then how can we say it's not okay for, probably the significant minority, if not majority of people who are working in mental health who have got lived experience, not actually drawing upon that in terms of how they help people. I mean, we're seeing it as an advantage these days, aren't we, to actually have lived experience. So it doesn't make sense to just automatically withhold it, does it? But I remember I had a lot of training in psychotherapy, and because it was still available in the 1980s. When I trained as a psychiatrist, and the principle of disclosure in psychotherapy is of anything, whether it's lived experience or anything about yourself, is that you've got to ask yourself the question: how is that going to help the patient? So you're not being self-indulgent, or you're not actually using the patient in a sort of a gratuitous sort of way. So that's the fundamental principle. When you're in a therapeutic interaction with a patient, it's about them, not about you. And so it's a pretty simple principle, but it does mean that you have got using your judgment. There may well be times when it's a very good thing to do to share it, but you've got to think. You can't just do it on an impulse or in a sort of an unthoughtful sort of way, I think. I don't know what Kieran thinks about that, and Brett, I wonder what you think.
I deliberately didn't jump in first, hoping that someone would.
Maybe I just put my foot in it, I don't know.
And I'm glad I did, because Pat, you've kind of summarised in a much more cogent manner what I was thinking. I have not personally shared with patients, but that's not to say I wouldn't. It's never come up as is the reality. There's been a couple of times with patients where they have thrown out comments where the presumption is that the doctor they're seeing, me, does not have a mental illness. And I might ask a question like, how do you know that? Or are you presuming? Or something along those lines to make them think, but it hasn't got to the point of discussing things openly. But I think there is value in it if the patient is seeking to explore that. If you're not doing it for your own benefit, and you're not, inserting yourself into that therapeutic relationship as the surrogate patient, then I think it can be valuable. And I think it will, over time, once that starts to become accepted, it will become an important tool.
So I on occasion do, okay, and I think that sometimes, especially fairly early on, I'm holding the hope and the optimism of the patient because they don't have it themselves. And I'm trying to give them some thought about them having a different future than the one they imagine. And sometimes with the right person, you can have a moment of engagement about, I understand how you feel, and I felt no hope and was incredibly pessimistic as well, but that actually isn't what happened, and this was my journey. So look, I think things are changing. I mean, I trained You know, I did the psychotherapy training as well, and I can hear the sharp indrawing of breath from my psychotherapy supervisor, but you know, that's life. I do occasionally, but I do, like Pat said, I think it's a case by case kind of thing.
Thanks very much, Brett. Anything from you, Tani, to add?
I think everyone else has summed it up pretty good.
One thing I do share with patients quite a lot is the fact that one of my kids has got a mental illness. You know, so I would share that with parents, you know, and just in a sort of a peer support type way, more than a psychiatrist type way, I would say. You know. And I think that's a massively underdone sort of area, the amount of support that the parents of young people get. I'm sure Brett would agree with that, working in child and adolescent. I mean, the parents have got get so little support from the system.
Look, I think parents, it's a very frightening and lonely place for a lot of parents with a child with a serious mental illness. There's no doubt about that. And yeah, I feel for them.
All right, I think we've got still 5 questions, and I think we're running out of time. I would probably ask each of the panelists to say a little advice before we finish up. So we'll start by Brett. Is there any quick advice that you, last minute kind of word that you'd like to say to everyone?
Okay, so quick advice. No, there's no quick advice. But I will elaborate more than that. Quick advice. Well, you know, I'm just going to go back to what I started off with. I think, you know, we have an opportunity now, and I think that we need to, you know, the worrying thing about all of us tonight is you know, Matt Sanders, who's a great Queenslander and did the positive parenting program, Matt used to hate it when I said the way to find a great parent is to run a positive parenting program, because the great parents would come out to do it. You know, the danger we have tonight is that we are people who are converted. I mean, you know, all the people that came online and others, we are the converted ones. I think we need to find a way to fundamentally spread this conversation to our profession. So any opportunity people get to do that, and I'm happy and hand in hand are happy to be part of that. Pat's made a career of being part of that, you know. Any opportunity we have to spread this message, I think, is crucial. So that's my last comment.
Yeah, I agree, Brett, and I think focusing on the profession is like a Russian doll, and the bigger Russian doll is the wider community. And I just want to mention that on the 21st of June, that there's a National Day of Action for Australians for mental health. So if people would like to get involved in that, and they can probably find out more on the website about that. But also, if you can help us, because as you say, that the converted are here, and the leaders and the people who've got the courage to stand up and you know, lead on these issues are probably on this call. So if you can help us with the broader mission and campaign, that would be great.
Thanks very much, Pat. Kieran?
I think the thing I would tell people is stop introducing yourself as a doctor when you meet people. You are more than that, and you should try to be more than that. Find something else interesting about yourself and talk about that instead. And the second thing would be, out of the 70 odd people we had on this list, I'm sure at least half have a story that would reflect some part of what Brett and I have talked about. If you've never shared it, share it with someone. Find one person you trust and share that story so that it's not as much of a burden as it is right now.
Thank you very much.
I feel like I have a hard act to follow, all 3. But I think my closing message would be that I think we're all human, and sometimes we forget that, and none of us are perfect. And it's really hard to accept that we're not perfect and that we're going to make mistakes and that we don't always get everything right, but it's okay to say that we're not okay, and it's okay to ask for help. So echoing everyone's message, I think reach out and use your friends and colleagues where you can. And also be supportive to those that you think aren't doing so well. Reach out to them and don't be afraid to actually ask them if they're okay and what you can do to help. That's the other side of the coin.
Thanks very much, Tani. Thanks everyone for coming and for participating. It's been a really rich discussion and really useful. This session is being recorded. Is that going to go up on where, Tani? Where can people find it?
We'll, once the recording's available, we'll, I guess, put it up on various sites.
Social media.
So we can put it up on our Facebook page. We can send it to Australians for Mental Health as well, and Kuyong, and have it on our website so that people can watch it back, or those who missed can also watch it. I think the other thing I just wanted to mention was thank you to Australians for Mental Health for inviting us to join in this, and also thank you to Kuyong for their support, and thank you to all the Hand in Hand team and those from Jacumza and JCU who helped put this together, because we really appreciate everyone banding together for this event.
Thanks very much, everyone, for coming in and for participating, and we look forward to the next one.
Thank you.
Thanks for hosting, Nadine.
Thanks.